Emily Ricotta's presentation. So let's see whether
Yes.
this
Can
sounds
you hear
good.
me?
Absolutely, very nice. And
Excellent.
so let
Okay.
me introduce you first. This
Sure.
time
Thank
I
you.
forget it. Sorry. We will hear about Emily's project now. She's an assistant professor of epidemiology in the department. Oh, I did so. I forgot. I already did, and then we had this audio problem. Now I'm really confusing here. So you can start right away. My apologies.
Perfect.
We know
Thank you
all
so much.
about
I'm
you.
so sorry for the audio problems, everybody. But I am going to do my best to make it worth the wait. So I am honored for the opportunity to present the project today. This is the Global Infectious Disease Standard for Epidemic Settings. And you've heard a lot about data access and data quality in the previous talks today. My project really tries to target one of the roots of that issue, aiming to improve data quality at the source, increasing its availability and impact for everyone. So I have to give a quick disclaimer because I'm a member of the US government. These opinions today are my own and not that of my employers. Probably explains the computer issues. So we are all very familiar at this point with the urgent need for information at the beginning of an infectious disease outbreak. Do you remember asking yourself, who was getting infected? Who is the most vulnerable to disease? What are the risk factors for transmission? What are the symptoms of the illness I should be looking for? How many people are dying? And are interventions available? Do they work? The answers to these questions are critical for public health response and the creation of effective policies. And honestly, we ask the same questions and need the same answers in every epidemic, regardless of pathogens. The problem is that we trade data quality for speed. We need information quickly to respond, of course, but poor quality data harms individuals, diverts resources, and undermines public trust. And not all questions can be answered with existing data, such as surveillance systems and medical records, things that are stood up usually at all times. This is where research studies can help fill some of those gaps. Observational studies in particular are quick to implement, they're generally inexpensive, and they can be more ethical in certain situations, which make them ideal in epidemics. However, observational studies in particular are challenged by inherent methodologic shortcomings, for example, bias, confounding, small sample sizes, among others. This leads to a preponderance of low-quality data, resource waste on repeated studies trying to answer similar questions, manuscript retractions, medical reversals, and general confusion by the public about what they should be doing to protect themselves. So I asked, why can't we gather high-quality research data quickly? Frankly, I think we should be able to, but there are many barriers that exist in the current landscape. There's a lack of global consensus about what questions we should be prioritizing given limited resources. There are no wide-scale standardization efforts early in epidemics. Generally, it's a free-for-all of people using whatever resources they have to help solve the problem. Insufficient technology and infrastructure to ensure data quality, especially in places at high risk for disease emergence. There's little to no dedicated funding for data collection, management, and long-term availability of data, which can be very problematic if epidemics span for long periods of time. There's no consensus rules on data access and sharing, and there are no agreed upon data sharing platforms, or there are way too many options. But not all hope is lost. There are efforts that are underway to improve data collection, specifically in epidemic settings. These include things like the development of common data elements, which are standardized, precisely defined units of data that are collected consistently across studies to ensure their compatibility. There are some efforts to standardize protocols. Many of these focus on randomized control trials, but for example, the Unity studies are developing a pandemic preparedness research framework for conducting targeted research interventions. And there are also the efforts to make and follow the FAIR principles, so making data findable, accessible, interoperable, and reusable. Unfortunately, there are still gaps in that current landscape. Generally, these efforts are focused on either the variables to be collected or data standards and the underlying semantics and metadata, but not both simultaneously. They're generally not focused on research data collection, especially those of observational study methods. Usually the efforts that I am aware of have focused on surveillance data or outbreak response. Finally, there are minimal considerations for standardized de-identification methods. And privacy and confidentiality are the expectation for research data. And it's not as much of a consideration for data that's gathered through public health response. And so that has not been something that has been incorporated into much of the current efforts to improve data quality. So this is where my project fits in. I'm hoping to build on what has been done and also fill in some of those gaps that I just mentioned. So let me introduce the project's objectives. First, we want to identify research elements that are crucial to early stages of any infectious disease outbreak. Second, we plan to elicit expert input on the concepts and standards that should be collected for research use. Then we're going to finalize the product, including developing electronic data entry forms and making it accessible for others. Throughout the project, we will be conducting outreach to raise awareness for the project, and we'll really aim to get global adoption following project finalization. So when it comes to identifying research elements, history repeats itself. We have had pandemics since the beginning of humans, and throughout all of these, we need to know the same sorts of information. And so we have started doing a scoping review of historic outbreaks to help us understand what research data actually gets published and is available early in epidemics. We're focusing on observational study designs published within the first 6 to 12 months following an outbreak declaration. You can see in the timeline along the bottom that the different epidemics that we are focusing on. And we have developed a scoping review protocol that is available on OSF. We're hoping to be able to answer the questions: what are the critical data elements common across epidemics? What are the gaps and limitations of using observational studies? And can published data be traced to tangible impacts on policy or research? For our second objective, we will be eliciting expert input using an IDEA protocol, or investigate, discuss, estimate, and aggregate. This is a quantitative expert elicitation exercise, which is similar to a Delphi method. You can see the process steps along the right-hand side. First, we'll be gathering potential data elements, which is what we are doing in Objective 1. We will then conduct an online survey of experts to elicit their thoughts on data elements, standards, and de-identification methods. We will have facilitated discussion to interrogate the reasoning behind their decisions in the online survey, and then we will iterate steps 2 and 3 as many times as we need. We hope to have a final facilitation in person with a subset of the experts. And finally, we will mathematically aggregate the results. We've chosen this particular protocol because it encourages discussion and structured debate of topics. It increases process equity by facilitating input from a wide range of experts. For example, we can have individuals who collect data in communities all the way up through international policy experts participate. And it also ensures practices are sensitive to disciplinary, regional, language, and other contextual features that are significant during epidemics. And I do have experience convening international expert groups for this type of work. Here you can see a photo from a workshop I convened at the National Institutes of Health last year on standardizing the conduct of observational studies in epidemic settings. And we have a report that is available on OSF if you'd like to read more. Finally, we want to finalize the product, including developing electronic entry forms. We really want to make sure that this is accessible and that it's not just piecemeal, a collection of variables or some data standards. We want to have a minimum set of required data elements and the data semantics and metadata that go along with that. And you can see an example along the bottom what that looks like. That includes the units of measure, the data type, a description. We want to have standardized de-identification rules, as I mentioned, and We also will have electronic data capture and educational tools. You can see an example of the electronic data capture form here. We hope to be doing this following the Clinical Data Interchange Standards Consortium, or CDISC's, validated and accepted methods for creating data standards. One of the project team is Ms. Beth Leroy, who is the head of standards development at CDISC. And we are anticipating that by following their validated method of developing standards, it will increase trust in our product and facilitate wider outreach to relevant parties to encourage uptake of our standard. So I want to close with, infectious diseases are not going anywhere. And it is imperative that we use the time we have now before the next threat happens to prepare ourselves and build the infrastructure and resources that we need to respond. And my hope is that this data standard can have global impact. It will be usable at all levels, from community researchers up through international study collaborations. It will reduce the time from disease emergence to actionable findings, including help increase data quality for early data models and simulations. It will improve data quality and reporting in general, so hopefully we'll see fewer retractions. Will increase the public confidence in infectious disease evidence and policy, which we know is something we are struggling with right now as a community. It will encourage data sharing through interoperability and enhance global data equity and trust in data from all over. So with that, I'll end. I just want to highlight my project collaborators without whom this project would not have gotten off the ground. And we really need global support for adoption of this project. So if you have any interest in learning more about this, I would love to hear from you, as well as any recommendations. And with that, I am happy to take questions.
Thank you very much. Very clear presentation. And I know that Gauri and Yuval have questions. And so I don't know who wants to